And I would like to welcome everyone to today's webinar. My name is Michelle Leach, and I'm Professor in Radiation Therapy here at the discipline of Radiation Therapy at Trinity College in Dublin in Ireland. So you're very welcome to today's webinar, which I know is going to be fantastic. And that's because I'm joined by Nicole Harnett. And Nicole is Director of the Accelerated Education Programme of the Radiation Medicine Programme at Princess Margaret Cancer Centre in Toronto, Canada. Nicole is also an assistant professor in the Department of Radiation Oncology at the University of Toronto and the director of the curriculum for the Institute of Medical Science, Faculty of Medicine, also at the University of Toronto. So she's extremely well placed to present her experience in starting advanced practice radiation therapist roles in Ontario in Canada. So just a small housekeeping issue. I'm sure there'll be lots of questions for Nicole. And we're going to use the Q&A function for that, please. So the chat doesn't work, so please use the Q&A, and you can type in your questions at any point and I will put them to Nicole at the end. So if that's okay, without further ado, Nicole, I'll ask you to share your screen if you don't mind, and we'll just check again that everything is working as it should be, which it looks like it is. Perfect. So I'm going to stop talking now and hand over to you. Thank you very much.
Oh, thanks, Michelle. Very pleased to be here to do this presentation. One note I will say is I've got a little bit of the sniffles, so I may have to stop and blow my nose along the way, but we'll just press on. Thank you so much for having me. My experience with developing advanced practice is long. I think when we started the project, we thought it would be, a year or two, and here we are 20 years later, still continuing to try to move the needle on advanced practice radiation therapy in Canada and hopefully around the world. So what I want to do is share some of my experiences. I know that in Ireland, you guys are fairly new in the area. And so I've tried to focus some of my talk on, sort of early learnings and early experiences, but I will sort of talk about, take us right through to where we are now. But I'm more than happy during the Q&A to ask questions about any point in our trajectory. Obviously, this work has been done by so many people in so many places. So I'm here representing sort of the collective voice of everybody that's been part of this. And I'm grateful for you guys joining today. And I just need to get my slides going. So in the beginning, when I was much younger and...
Sorry to interrupt you. I don't see your slides.
Oh, did they just go away? Okay.
Yeah.
Sorry.
They just went off, I think. Yes.
There we go.
I see them there. Thank you very much.
Okay. Thanks. A long time ago, our radiation medicine or our radiation treatment programs were suffering from chronic health human resource shortages and extremely long wait times. We were shipping patients outside of the province and outside of the country to get their radiotherapy. And our local government sort of spoke out and said, we've tried the same old. We're looking for now new, innovative and non-traditional solutions to our workforce issues so that we can staff a department that can be sustainable and can meet the needs. And this was in Ontario. So Ontario is a province of Canada, and it was our Ontario government who said, we want to hear interesting ideas. I just stopped sharing again, and I don't mean to, but my mouse...
no problem.
I've got it now.
It's misbehaving. That's all right.
Yes, it is.
Good again? Yeah.
Okay, let's try it. So in 2002, as a radiation medicine discipline and a group of leaders in radiation therapy, we sort of sat back and thought this might be an interesting time for us to step into the mix. And what did we know? Well, we knew that task shifting was being touted as a strategy to help deal with health human resource issues in other areas. So it was coming up as a prevalent strategy for dealing with the HIV crisis in Africa, among other places around the world. So the World Health Organization was speaking quite openly about the concept of task shifting. So we knew that that was a strategy that was being used in other areas. We also knew that the Institute of Medicine had published its landmark book, Crossing the Quality Chasm. And in that book, they spoke heavily about interprofessional and interdisciplinary work as the best model for care. So, trying to distribute activities and responsibilities in a logical and rational format to make sure that the patient's receiving the best care at the time that they needed the care. And of course, we knew advanced practice nursing was building momentum, their presence was being felt, and they were publishing their evidence of how advanced practice was impacting on the care of patients, not necessarily just in cancer care, but across the entire spectrum. So in 2004, we put a proposal, we gathered all of those thoughts, and we put a proposal to our government to say, we think that an advanced practice facilitated way of working might actually have positive impact on our radiation treatment system. So we put together a proposal about new ways of working, and our question really was, could APRTs, advanced practice radiation therapists, contribute to a model of care that could add effectiveness and efficiency to the existing model of care? So that was the question we put forward. The government said, we like the idea. Basically, we looked at, this is a very low fidelity diagram of what the radiation therapy workflow looks like. But you can see each of sort of the critical time points for the patient as they move through their treatment. We knew there were problems, wait times, people couldn't get into the system. We had throughput issues. So once they were in the system, we had bottlenecks and we had gaps that were preventing patients from moving very efficiently from consult or referral through to their actual treatment. Patient satisfaction and patient experiences were suffering. We had unprecedented levels of overtime for our staff, which was leading to injuries and burnout. We also noticed that our equipment wasn't being used in a rational way. There were areas and regions around where our cancer centers were that weren't getting access to treatment because they weren't getting referrals, because they couldn't get treatment, and referral rates had dropped. So all of this had led to a whole series of issues and bottlenecks within our system. We hypothesized that adding an advanced practice radiation therapist could add capacity to the system. It could add quality and safety to the processes in place. It could accelerate the implementation of best practices. So a well-positioned and a well-trained advanced practice radiation therapist might be the right person to start translating existing knowledge into practice, or even generating new knowledge on better ways to treat patients. We hypothesized that it could increase access to services for our underserviced population, so the people outside of sort of our metropolitan areas that weren't getting referred for treatment. And we also thought that it would create time efficiencies for radiation oncologists. And with that time, the radiation oncologists could focus on more complex patients, less well patients, as well as other academic endeavors that are required to keep advancing practice. So back to the question, could APRTs contribute to a new model of care that could add effectiveness and efficiency to the existing model of care? Once we got funding, we set out upon our way to address that question. The thing is that question is loaded. And as we sort of started to deconstruct the question, we really set out our plan of action, because APRTs, we weren't even sure what advanced practice would look like in Ontario. What is advanced practice? How is it defined? And what would it look like in our province or in our jurisdiction? Model of care. So we needed to actually examine the existing model of care to find out what a new model of care could look like. So we had to look at, what was the existing model of care? Where were the pain points? Where could advanced practice in radiotherapy make a difference, as opposed to advanced practice nursing or physician assistant or some other kind of professional coming into the mix? And what did we propose would work? And how would we know that it's working? So how would we measure the impact of adding an advanced practice radiation therapist? These are all loaded questions. And once we started to deconstruct the question, I realized that the work ahead of us was not going to be 1 year or 2 years, but in fact, a decade's worth of work and research and collecting data. One of the frameworks that was coming to the fore, and interestingly enough, Denise Bryant Lukosius is an advanced practice nurse. She lives about hour and a half away from me. So she was working in the city of Hamilton on building consistent, standardized, sustainable advanced practice nursing. And I was on a task group with her looking at a framework that would help guide the development of advanced practice nursing. Now, this didn't get published till 2004, but I had been working with her in the years leading up to the publication of the framework. And this is called the PEPA framework. And it's actually a really clear 9-step process that talks you through the different stages of actually developing a new healthcare provider. So this model was built for advanced practice nurses, but you can see I changed it to APRT from APN because this model is useful. And that was the reason I was sitting on this committee, was because Denise wanted to make sure that the model was sort of profession agnostic, although she was building it specifically for advanced practice nursing. So whenever I'm sort of stuck, I have a problem with advanced practice development, implementation, sustainability, I go back to the PEPA framework and remind myself what step I'm at and what I need to do to get past that step. So if you take almost anything away from this talk today, it's that the PEPA framework is a really nice guide for the steps that you need to go through to actually develop well evidenced and establishing sustainable advanced practice roles. So we started out with a feasibility phase, and this could be the phase that you guys are at. You maybe are onto the demonstration phase, but really we needed to sort of dive into the literature, find out how people are defining and describing advanced practice. Then we had to overlay what would this look like for radiation therapy advanced practice. And we had to sort of articulate what advanced practice and radiation therapy would look like, because as you can imagine, it was a very vague, very undefined concept at the time. And what needs in the system could be addressed? If we could build an advanced practice radiation therapist, where could we deploy them in the system where they would have the greatest impact on system efficiency, effectiveness, and ultimately on patient outcomes? So we built this theoretical framework of what in Ontario we envisioned advanced practice to be. Now we adapted this from, there's some very well-known frameworks and models on building expertise in professions, as well as what advanced practice might look like. And interesting little piece of trivia is the original sort of development of expertise was built by a team of brothers, Dreyfus and Dreyfus, who were actually studying fighter pilots. And the US Army had said to Dreyfus and Dreyfus, who were psychologists, we need to figure out how to build fighter pilots more quickly. And so they started to examine what are the elements and characteristics of developing expertise and beyond that are necessary to make competent fighter pilots. And it turns out that the model that they built is adaptable to almost anything where you want to build expertise. And this is where we landed for radiation therapy. And we've published some work. If you want to go and look sort of at the theoretical framework, you can go to the paper and have a look. And really, when we look at this, fun diagram of squares and triangles and circles, we wanted to figure out what could we make better. Here were the problems that we had articulated, and what could advanced practice make better. So that this helped us focus where we wanted to explore and collect data. If you take anything else from this talk today, it's this model for improvement. So this is the cornerstone of how we approached all of our work dealing with advanced practice. And during the feasibility phase, we actually got funding to deploy 5 pilot advanced practice radiation therapists in our Ontario cancer centers. And really what these were, because advanced practice didn't exist, these were 5 identified highly trained and high functioning radiation therapists, and we deployed them in the cancer center to start imagining what advanced practice would look like. And as they sort of started to figure out, where advanced practice could go, they started to try to develop competence. So they identified skills that they would need to acquire to be what we were slowly building as our identity around advanced practice in radiation therapy. They also imagined where in the system they could have an impact, and they started to collect baseline data. So a really common example is, advanced practice radiation therapists conducting on-treatment reviews. So if we were going to insert an advanced practice radiation therapist into on-treatment reviews, what would the impact be? The only way we can know what the impact is if we know what the current state is. So how often were patients being seen? How long did it take for a radiation oncologist to conduct an on-treatment review for well patients as well as for unwell patients? What were the skills? What were the activities? What were the results of the reviews? How satisfied were patients with these review appointments? So we started to collect all of those kind of baseline ideas, and we started to build and test our ideas around, if we were to transfer some of the skills or some of the responsibilities for on-treatment review, how much time would that save the radiation oncologist? How much better would patients feel about the experience that they had? So all of these, these singular activities started to blow out into a list of activities, and it was just constant iteration. So we use this model of improvement to articulate, what are we trying to accomplish? How will we know that we've actually accomplished anything? And what change can we make that will result in improvement? When we knew that, we would go about planning it, we would do it, we would study it, and then our results would feed back into the model again so that we could start to refine our idea about what knowledge, skills, and judgment would best impact whatever the activity was for the system and for the patient. Once we had a clearer idea of what advanced practice might look like in Ontario, we went into what we call our demonstration phase. And just to note that as we gathered evidence and as things were looking positive, we constantly reported back to the government to say we're making good headway. Can we get access to more funding? So this was this annual cycle that we had with the government. We would report on our work, and they would, based on the success of our work, award us more funding to continue. So during the demonstration phase, we wanted to figure out how, at a sort of system level, can we build an APRT facilitated model of care, and what is the impact on the patients, on the department, and on the system. We deployed 17 pilot CSRTs or APRTs in 6 centers. They all had a role articulated. So some of them were focusing on breast cancer. Some of them were focusing on head and neck cancer. Some of them were focusing on palliative radiotherapy. And they each had their individual organic journey, but as they were making their field notes of what they were doing, what they were learning, what they were using to measure their competence, we would collate that information and share it amongst all of the pilot positions so that we could find some synergies and share information so that we could slowly start to build a unified approach to advanced practice. Each of the positions were deployed or identified based on the needs identified in that department. So if a department didn't treat any complex head and neck patients, there was no point developing a head and neck advanced practice radiation therapist. So we had 5 or 6 different sort of flavors of advanced practice that were being deployed. But as they worked through the demonstration phase, a lot of commonalities started to bubble to the surface. And we'll talk about those later. In this phase, if you remember, the model of care had 3 questions and then this iterative Deming cycle. This was just used over and over again to try to measure, to find, get our results, and then act on those findings so that we could constantly refine what advanced practice would look like in each of these specializations. And so we articulated in our research project that there were 3 pillars that we thought that the impact would be most important. And the first one was actually building capacity. So making sure that we had room in the pipeline for more patients to come in. This was, of course, of great importance to the government. It was of great importance to the departments. The second pillar was the quality of care. So were we making it possible for patients to move through the system more quickly? Were they getting better care along the different points in time? Were we reducing the number of errors? As we know, handoffs and having multiple professionals involved in the care of a patient can result in an increase in errors or miscommunications. And then the third pillar was around innovation. And it's just interesting to note that the government didn't want to call it research because they didn't want to be seen to be funding research. So we had to call it innovation or knowledge translation. And these little bubbles just represent how the different pilot APRTs were shaping their role based on what their department needs are. So if the department needed to, it wanted to contemporize its palliative radiotherapy program, this APRT might be focused really on gathering information from the environment, reading the literature, finding out what best practices were, and translating those into practice. Whereas this pilot APRT over here might be focused really heavily on building capacity in the system and improving quality of care. And then other roles were focused on all 3 pillars. So each individual APRT role was built based on what the department needs are. And as such, for us to measure impact, we had these 3 headings under which we were trying to gather data. Quantity. So were we saving the system? Were we able to do more with the same, or could we do more with less? How much more quickly could a patient move through the system and get out of the system and back into their primary care in their communities? The quality of care was focused on the patient experience and outcomes, as well as provider experience. So if we were adding another member to the healthcare team, was that too chaotic for the existing members? Were we like creating work as opposed to alleviating work? And then under the heading of innovation and knowledge translation, what were we doing that was going to bring promise of improved patient treatment care and outcomes? So implementing new techniques, the adoption of new technology, the implementation of best practices as the information would come from the literature. And what we found, again, back to this diagram, we found that at various points, our CSRTs or our APRTs were having a positive effect. So they could conduct new patient consults in some areas and make a decision to treat. So it was expediting the time from a referral for treatment to the time that the patient got into a decision to treat and into simulation. They could prescribe radiation treatment, and they could order additional imaging and laboratory tests where the information was seen to be insufficient to make such decisions as decision to provide or to deliver radiation therapy. They could contour relevant target volumes. They could conduct field placements and clinical markups. So for example, we had one of our pilot CSRTs or APRTs was working in a skin clinic. And so a lot of the work was for BCCs and SCCs, just doing simple clinical markups that required a radiation oncologist. Well, with sufficient training, that actual activity was delegated to Emily. This was back in the day when SBRT was new, and first day images for SBRT were very anxiety inducing. But a properly trained APRT could actually approve these images on the first day, and they could make decisions around adjusting treatment, starting, stopping treatment, or a decision to replan. So if you look at an image, on day 13 and it's not looking right, our CSRT or APRT could actually make a decision to hold treatment and either replan, give the patient a pause, and so forth. They could also do medication adjustments based on their training, and obviously do treatment toxicity and management of toxicities either on treatment or at follow-up. So these were the different areas where our CSRTs or APRTs were identifying and starting to measure impact on the system. So as we collected evidence, and it took years to sort of collect definitive evidence, but this little table here shows that this is really an impact on patient capacity. So how many additional patients could come into the system in an advanced practice facilitated model of care? On average, and I've got 3 buckets here because our CSRTs or APRTs sort of came in waves. So the senior CSRT wave, they were able to increase capacity in the system by 14.2 patients per CSRT per month in whatever service or department they were working in. The junior CSRTs were actually able to increase capacity per CSRT by 17 patients a month. And our new CSRTs, who were fairly new and hadn't reached full function yet, were having an impact at 5.5 patients per CSRT per department, which we thought was an excellent finding. We also tried to measure the time savings for radiation oncologists. So by redistributing tasks, how much time did the radiation oncologist save by being able to shift all of the on-treatment reviews of early treatment patients. So for example, all the breast patients who were in the first week or 2 of their treatment would be seen by the APRT, and the APRT would only refer that patient to the radiation oncologist if there were unusual findings at treatment review. And we found that on average, the senior CSRTs were saving radiation oncologists on their team 23 hours per month. The junior CSRTs were saving 15 hours a month, and the new CSRTs were saving 24 hours per month. Now, what we couldn't do was determine how the radiation oncologists were using that time. It was our hypothesis, and anecdotally hearing from the oncologists that it gave them time to focus on their research on managing more complex patients, building new treatment protocols, focusing on translating knowledge into practice. But we don't have publishable data on that. As far as quality goes, this is just a snapshot of one of the metrics that we used under the heading of quality, and that was around patient satisfaction. So different CSRTs at different time points in their journey implemented a validated patient satisfaction questionnaire to patients who were not treated or cared for by a CSRT or APRT. And then they implemented the survey with patients who were being cared by an APRT or a CSRT. And you can see that while the light blue bar is slightly, the score is slightly higher, it was not seen to be statistically significant, but I still do like to point it out. But our goal in this regard was to not have a negative impact on patients' experiences or their satisfaction with their care. And so we were able to prove that we weren't having a negative impact on patient satisfaction with their care. We also interviewed the radiation oncologists who were directly supervising and working with the APRTs and CSRTs, because as I mentioned, we wanted to make sure that the team wasn't negatively impacted by adding this new team member to the existing team. And the direct supervisors articulated a number of benefits, including quality program innovation and service improvement. And they identified cost savings as a potential positive impact. Of course, financial pressures was also a challenge because trying to find funding for advanced practice radiation therapists was complicated in Ontario, and it is complicated everywhere. And then under innovation and knowledge translation, this was hard to measure. And if and when somebody articulates or identifies a good way to concretely measure and reliably measure innovation and knowledge translation, I'm all ears, because this is always a work in progress. But what we decided to do was sort of identify the increase in scholarly contributions. So one of the things that's important about advanced practice is contribution to the body of knowledge for radiation therapy, radiation medicine. And so we tracked the number of presentations, peer-reviewed publications, book chapters, and awards and honors that were being received by our CSRTs and APRTs over time. This is up to 2015, because we had to give up after that. It was getting to be too difficult to track. But you can see a nice trajectory here for our CSRTs over time. Once we were able to show in a variety of ways, and I've just given you a snapshot, but in a variety of ways that our APRTs and CSRTs were having a positive impact on the system, we moved into what we called our sustainability and integration phase, which the fundings from the ministry stopped in 2016, but this is still an ongoing project because we're not there yet. We can't walk away from this and say we've done our job. We still have much to do. And the questions that continue are, what are the things that we need to do to make the APRT a permanent, recognized member of the articulated existing treatment team in radiation oncology? And there's regulatory issues, there's professional issues, and of course, there's still lingering financial issues. So making the role more permanent is, we needed to find ways to make it official and recognized. We needed to find ways to make it acceptable or to have it accepted by other members of the team. And we needed to try to find ways to add this new funding line to the radiation medicine budgets. So the first thing we did was we collaborated with our National Professional Association. They saw the work that we were doing. They identified it as an important move forward for the profession. And we worked together to share the work that we had done in Ontario with the national organization to develop an advanced practice certification process. So in Canada, to call yourself a certified advanced practice radiation therapist, you actually have to complete this 3-phase process that is run by the National Association. So we piloted a project in 2017 with 3 of our most senior CSRTs, and then we officially formalized and launched the process in 2018. To date, we've had 8 CSRTs or APRTs successfully complete the certification process and now have the credential of APRTT behind their name. We've got 2 additional people in the process. COVID put a hold on a lot of it. I don't know how COVID was managed in other parts of the world, but in Ontario, it was very much an all hands on deck endeavor. And people who were working in very specialized advanced practice roles were pulled back into other activities to help manage during the time of COVID. So a lot of our CSRTs or APRTs who would have entered the process at that time have not entered that process or are just starting to trickle in now. As far as where we are right now, we've got 28 positions in Canada. So 26 of them are in Ontario, and 2 are now in a new province, not in a new province, but in a province outside of Ontario. So we're starting to expand beyond Ontario. In Ontario, the concept is fairly accepted and moving carefully. And but we're very happy to see that we're now starting to spill outside of the province of Ontario. And this is just sort of a little visual to show you sort of what advanced practice looks like. So some of our APRTs have been in their position since 2007, and are still practicing in an advanced practice way. And then you can see sort of those three initial waves of CSRTs that came into the system. But after proof of principle, we've had a steady trickle in of additional CSRTs into the province of Ontario. So I just wanted to give you a little visual snapshot of how APRT continues to grow in Ontario. And this is just a little look at sort of the areas where they're specializing. So you can see the majority of APRTs are specializing in palliative radiotherapy. And this has kind of gone hand in hand with the development of what we call rapid access clinics. So rapid access radiotherapy, where in many instances, the APRT is running rapid access clinics. So every morning they see a number of patients, they assess them, they do a history physical, and then they recommend treatment or not treatment for these patients. They refer them to other services if they're not suitable for radiotherapy. And it's kind of a one-man show. And it's proving to really address urgent or emergent cases in Ontario and getting patients onto treatment much more quickly. We've got a couple of APRTs focusing on the development of SBRT or SRS. So they're taking the concept of hypofractionation and deploying it to sites as necessary. They're doing the legwork, they're getting the policies and the techniques, workflows up and running. We've got 3 CSRTs who are actually working in brachytherapy. So 2 of them are working in gynae brachytherapy, and one of them is working, I guess all 3 are working in gynae, and one of them is actually working in esophageal brachytherapy as well. We've got a number of head and neck CSRTs. As you know, radical head and neck radiotherapy is quite complicated, and our patients require close monitoring. We've got 3 CSRTs focusing in breast at different time points. And then we've got 4 who are focusing on, of course, the new paradigm, which is adaptive radiotherapy. We have, as a group here in Canada, curated over 300 peer-reviewed publications, posters, book chapters, and we have sort of compiled it all into a Zotero folder. And I, would be happy to share that. I'm also happy to share any research that we have that you can't find. We've also noticed an increase in invitations for our advanced practice radiation therapists to departmental, organizational, community, and government tables. So their voice is starting to be recognized as important to, strategically planning what's next for radiation medicine in our province. We've also established an Ontario-based community of practice, which now that we have new and developing APRTs outside of Ontario will be expanded to a national purview. And we've also established an international community of practice so that people who are in disparate locations trying to develop advanced practice on their own can actually be part of this community of practice and benefit from the expertise and knowledge around the table. We're also exploring, in Canada right now, advanced practice is solely focused in radiation therapy, and we obviously think there are many opportunities for it to expand to diagnostic or medical imaging, and so we're actively working with our national association to do that. We've also noticed that our APRTs are increasing their grant capture. So our granting agencies are recognizing them and their work as valid and awardable. So we're quite happy with the progress we've made. Of course, it's never enough. There's always more to do. We're constantly trying to collect evidence on our impact in different ways and disseminating it as far as possible. We want people to learn from what we've learned from our mistakes and from our successes. We're still working on the stability of the role in our health human resource team. We're looking for permanent recognition and funding. These things are ongoing. One of the things that's very interesting is in our country, we have a national certification process, but each of our provinces has their own licensing and regulatory framework that you have to align with to get your license to practice. So we have just recently, in the last couple of months, struck a task group that's going to be approaching the provincial governments to propose that they recognize advanced practice as a separate classification of license to practice, much like the nurses have done in Ontario. So if you want to practice as an advanced practice nurse, you have to complete the requirements to be an advanced practice nurse, and you have to qualify for the advanced practice license to practice in Ontario if that's where you're practicing, or in Alberta if that's where you're practicing. So we are actually proposing now to our provincial governments that they recognize advanced practice in radiotherapy as a separate classification. And we need to complement our initial focus on task shifting by looking at the new spaces. So not only should we be sharing what is in existence, but we need to look at where advanced practice in radiotherapy can actually fill spaces that currently aren't filled with our new and hybrid technologies, with the implementation of AI into everything that we do. Our increase in multidisciplinary care, and the fact that evidence is showing that multidisciplinary approaches to care results in better patient outcomes. There's a big void globally in access to radiotherapy, and what can advanced practice in radiotherapy do to help those regions improve access to care and the quality of care. And of course, there's many other elements, survivorship. I can think of a ton of areas where advanced practice radiation therapy can move into new spaces as opposed to just sharing existing tasks. I wanted to reiterate that the work that I'm talking about today is the work of hundreds of people, early champions and visionaries in radiation therapy who were with me at the outset when we started this work. There's been over 40 CSRTs and APRTs in the province of Ontario who have come, gone. As I mentioned, some are still here, some have retired. So we've got early birds, we've got the people who've been around for their whole career, and new people trickling in. The people who have had the courage to blaze new trails, as some of you will find as we start to dabble in advanced practice in Ireland. There will be issues of territory, there will be issues of non-believers, people who think that it's wrong and not the right thing to do. Obviously, my National Professional Association, who has constantly given us a platform to continue to do our work, and my international support group. So people like Michelle Leach and Mary Coffey and others around the world who are so inspiring and keep us pushing forward. So with that, I'm going to close my formal talk, and I want to say thank you for your attention. I also wanted to give you my email address. I'm available anytime to answer questions from people, no matter how big or how small. So that's really what I wanted to leave you with, and I'm happy to answer questions from anybody. Or comments. If you have a comment about something that resonated with you, or something that didn't quite make sense with how you understand advanced practice, I'm open for debate, questions, comments.
Thanks a million, Nicole. That was amazing, as always. And it's, no matter how many times I hear you talking about it, I think I learn something new from you every time. So that's a real skill that you have. Fabulous. Thanks for taking us through that incredible journey, really. I'm going to start, obviously, I have questions, as you know, I always do, but I'm going to start with our audience questions. And the first one there is from Sam, who really enjoyed your talk and said, what's the healthcare model in Canada? All public or public-private? Probably different across Canada is so huge. Is it different across the country, or?
It's not. Canada is a public healthcare system.
Okay.
So the healthcare system is funded by Health Canada, but Health Canada gives the money to the provinces to then use as they see fit. But we have no private healthcare.
Okay.
Well, that's a lie. Sorry, I don't mean to lie to people right off the hop. There are little bits of, there are little pockets of private initiatives, but they are not endorsed. They aren't funded. They're renegades. So they're popping up, and Canada is on the precipice of debating a dual model. But for now, it is completely social and publicly funded.
Okay. And so that actually, while others are thinking of questions, that brings me to one of my questions, which is something that is a major issue, I suppose, in this country, and I'm sure in others as well, is the funding model for APRT. So maybe, I don't know, I mean, technically here in this country, we're all, public as well. I mean, there's obviously people have private health insurance and there's private centres, but technically anyone who has cancer can obviously attend a public centre, if you're resident in the country. But, we have lots of issues, I suppose, in trying to get our point across about the benefits of APRT to the government. And I think people will be very interested in knowing how you got that started and what the funding model is.
So we started off, full disclosure, we got over $5 million, almost $5 million from our provincial government over the duration of our project. So from 2004 to 2016. So our pilot positions were fully funded when they started. And over time, the amount of funding for the actual positions decreased until we got to a point where there was no funding. And in the ministry's own words, we were victims of our own success, because what they articulated was that the findings and what we were reporting to them showed such a positive impact on capacity and quality of care that the departments themselves should be able to take their package of funding that they get and redistribute it to make it possible for advanced practice positions to be funded.
Okay.
Now, this was handled differently in every single department, so it depended on the administrator how they wanted to handle that. In some places, our APRT positions are actually funded through research grants.
Okay.
So some of the funding comes from a research fund, and if and when that research funding runs out, the departments are going to have to figure out, was this worth it, and do we find money? In our department at Princess Margaret Hospital, the senior administrators said that within the radiation therapy envelope of money, that the advanced practice radiation therapists were streamlining work such that it made sense for them to take some of that funding from the amount of money that was allotted for full-time FTEs in radiotherapy. Now, some departments think that that's crazy because they want to maximize the number of FTEs that they can fund. In our department, that was the rationale, because our people are streamlining care. They're making it easier to get patients onto treatment because they're doing a lot of the navigation. They're doing a lot of the coordination. And then in other departments, and this is rare, but some of the APRTs or CSRTs are doing work that's making it easier for the physicians to bill for more patients. So the actual partnership of the radiation oncologists are using that money because they're able to see more patients. They're able to bill more for their complex patients. They're using that money to fund APRTs. So it's been a lot of creative financing, and it is an ongoing struggle, not just in Canada, but I hear it from you, from everybody. We always talk about this, like, where is the money going to come from? The evidence that we provided to the ministry was such that they felt the positive impact should resonate with the department enough that the department can find the funding.
Okay.
That
okay.
I'm not a fan of that, but
Mm-hmm.
that's how it has.
Yeah.
That's where it stands.
Okay.
Now we are again with the legitimacy of the role. So we've got a national protected title for the people who go through the certification process. We are approaching all of the regulatory bodies across the country about developing a separate classification for licensure. One bit that we haven't done, and it was an oversight, is that we have an institute, the Ontario Health Institute, which sort of oversees all things health related. And they oversee the collection of data around health human resources. And they don't have a category for advanced practice radiation therapy. So our job and our work doesn't get captured in their mandate to collect data. So we've now approached them to say, we're here, here's who we are. This is our certification process so that we can get on that list. And then data will be collected and that will help perpetuate. So that was a level of work that we overlooked and are now trying to rectify.
Okay. It's quite complex.
Yes.
Yeah. Clodagh has a question and is asking you, is there any oversight by the radiation oncologist for new patient consults or prescribing? Or is the APRT autonomous?
So the APRT works autonomously. So they will their daily work will be autonomous, but their obligation is to review everything with their supervising oncologist. So an oncologist is still what we call the MRP, the most responsible professional or practitioner, but they have delegated to the APRT these activities. So if there was ever an issue, the APRT and the radiation oncologist would be responsible and be held to account. But we have mechanisms in place whereby if somebody proves that they're competent, an activity can be delegated to them legally, but both are still held accountable.
Okay, perfect.
It's a good question. And that's in Ontario because, as you can imagine, it's so diverse around the world. But even in Canada, the different provinces have different ways of handling the redistribution of these acts. So yeah, it's a complex question. But in our function, in our language, in our documentation, there is always an MRP assigned.
Okay, thank you. And Clodagh has sent you a thank you note.
Yeah, it's a good question.
Okay, the next question we have is from Susan, who also thanks you for your talk and says it was really interesting. What time frame were you given to prove the success of APRT to your health services? And Susan is also here, a manager here in Ireland, so I know she's thinking what I'm thinking.
Yeah. So naively we put our first pitch in for 2 years, but holy Dinah, we were wrong. Now, other places that are now developing advanced practice can leapfrog over a whole bunch of, because a whole bunch of people have done a whole bunch of work about envisioning what advanced practice is. What we think now is that if we understand what advanced practice in radiation therapy is, and we've got a fairly decent framework, and we know how to select the right people to fill those roles, we think that we can show impact in 1 to 2 years. So at the end of 2 years, when we first started, we were able to at least go to the ministry and say, we've got a really clear idea of what we want to do. We've got a really clear definition about what advanced practice. We've identified where in the process we think we can have impact, and we've identified mechanisms to measure that stuff. So I would say that the most robust data came probably after 5 years.
Okay.
Yeah. So it's not when you're trying to get a government on side, it's not a short story.
No. I hope you're hearing that, Susan. We have work to do.
but we report it every year on our short-term wins. So where for example, it doesn't take 5 years for an expert radiation therapist to learn how to conduct on treatment reviews for well patients. So they can learn to use the toxicity assessment forms. They can report back to the oncologist on what their findings are and what their recommended course of action. So we would report the small wins. This person has now had this act delegated to them, and we're building on that. So, it's not crickets for 5 years. You can report on the wins. But to really be able to show, like for us to show that 14 patients could come into the system every month for every APRT, that probably took us 5 years to get to that point.
Okay. Okay, I'm going to ask you one final question, if that's okay, and then we can wrap up. And that is, if you had, isn't hindsight wonderful? What would you say was your biggest challenge or your greatest challenge in getting that first APRT role?
In getting that first APRT, well,
I like to ask you something awkward.
Yeah, no, you're making me think, because I mean, the desire for advanced practice came quite organically from the profession. So that wasn't hard. We also, at the same time that it was organically coming from the profession, had some people around us who were champions. So very esteemed radiation oncologists in our country who saw that adjusting models of care was going to be the solution to our problems, not just now, but forever. And that we needed to be flexible and we needed to be innovative. I guess convincing the ministry and striking when the opportunity was there. So when we, our whole radiation treatment enterprise was going to hell in a handbasket, and we struck while the iron was hot and said, listen, you guys have a problem. We think we might have a solution. So I think finding the time when all of those things came together was the biggest challenge, because once we had those pieces in place, we could start, and we started small. And so I think that was probably the thing that required the most patience, was starting small. And there were a lot of detractors. There were a lot of people who said, like, I don't even know what you're trying to do. Like, this is a pipe dream. But as we started with a few believers, and we paired them with very capable future advanced practice radiation therapists, we started to notice that people were, like peeking over the fence going like, oh, well, why do you get to work with Lori? Like, why don't I have a Lori? Why don't I have a Grace? And so it's the patience to let it grow, because there was no option to go from 0 to 100. So I guess waiting for everything to align was a challenge, but once you reach that, the biggest challenge is patience. That's
okay. Well, that's a lesson for us all, I think. Okay, I think our time is up. I want to say thank you so much, because I really appreciate it. I know you've already had an extraordinarily hectic morning. So really, hopefully you can have a breather for a few minutes now. Really appreciate you joining us. And I mean, you've given us so much
for the invitation. I'm grateful. I love speaking about it. I would love to hear from anybody. So my email is open.
Thank you. Thanks, Nicole. You've certainly given us a lot to think about. I think that's for
well, good luck. And if there's any way I can help, let me know.
Thank you.
Thanks.
So thanks everyone for joining as well. And that brings our CPD webinars for this year to a close. So I hope you will join me in January for a totally different topic, will be presented by Professor Laura Marniol, who's a radiation biologist in our department, and it's going to be about sex, biological sex as a variable, and why it might matter in radiation oncology, which is a really interesting topic. So hope to see you in January, and for those who celebrate Christmas, have a good one. Thanks, everyone. Thanks, Nicole. Bye-bye.